Okay. Good evening, ladies and gentlemen, fellow colleagues from Saudi Arabia and from outside Saudi Arabia. We really are pleased and really honored to have you all participate with us in this important webinar. To introduce myself, I am Dr. Adil Tash. I'm a cardiac surgeon, but I also am the Director General of the National Heart Center. The National Heart Center is a center under the umbrella of the Saudi Health Council, the body responsible for legislating, regulating, and connecting and facilitating the connectivity between the different healthcare sectors and the different healthcare providers and different healthcare regulators in our healthcare ecosystem. It is a main player in our health sector transformation program, and the National Heart Center, at the National Heart Center, we are dedicated in, first of all, providing the essential knowledge for the community on how to prevent and how to early detect heart disease at their basic level of knowledge. And we are committed to our fellow healthcare practitioners, introducing to them different topics and going through the burden of that disease, going through how to manage or how to early diagnose and the disease and how to manage it. And management here has a spectrum of medical management, interventions, and surgeries. Today, the topic is a very interesting topic that is not talked a lot about, that is really underdiagnosed, not just in Saudi Arabia, not just in the Middle East, but all around the globe. Our speaker today is a distinguished speaker. Dr. Abir Bakhsh is a senior heart failure cardiologist. I came to know her really closely and worked with her at Prince Sultan Cardiac Center when she was leading the heart failure services there, and she was leading the heart transplant program. I learned a lot from her, and today we will learn more and more. Just before we dive in to the details about hypertrophic cardiomyopathy, I will share just a few introductory slides about this topic. So can you see my slides?
Yes.
Okay, good. So hypertrophic cardiomyopathy is one of the most common cardiomyopathies and affects all ages, sexes, and races. And it remains underdiagnosed and misdiagnosed. It is characterized by left ventricular hypertrophy, and it is characterized by left ventricular hypertrophy in the absence of another cardiac, systemic, or metabolic disease. So it is a genuine, just isolated left ventricular hypertrophy. Hypertrophic cardiomyopathy is a chronic myocardial disease largely caused by dysfunction in the sarcomere. It can be genetic in approximately 30 to 60% of cases. And the core pathophysiological features include left ventricular hypertrophy, hypercontractility, impaired relaxation, and excess energy consumption, and poor left ventricular compliance, leading the patient to have severe symptoms of heart failure. Left ventricular hypertrophy is frequently asymmetric. It could be from the symmetric form, but it is frequently asymmetric. There are two main types: an obstructive cardiomyopathy, or what we call HCM, and a non-obstructive cardiomyopathy. In the obstructive cardiomyopathy, this occurs when the thickening of the ventricular septum decreases the left ventricular volume and narrows the left ventricular outflow tract and reduces blood flow through the LVOT. The narrowing is usually dynamic and involves SAM of the mitral valve, and may need to address the mitral valve as well during the management procedure. And obstructive hypertrophic cardiomyopathy patients represent 50 to 70% of all hypertrophic cardiomyopathy patients. The non-obstructive hypertrophic cardiomyopathy patients are characterized by cardiac wall thickening without LVOT obstruction, and we do not have decreased blood flow through the LVOT. Just to go on to and talk a little bit about the burden of the disease, hypertrophic cardiomyopathy is viewed as a rare disease, and it is likely that only a fraction of patients with hypertrophic cardiomyopathy are diagnosed and treated. In the United States, the prevalence varies between 1 in 500 and 1 in 200. Now, if we reflect that to Saudi Arabia, we have approximately, if we say 1 in 500, we have approximately 60,000 patients. It's 700,000 patients in the US, but it's 60,000 patients. In the US, from those 700,000 patients, only 100,000 are diagnosed. Now, in Saudi Arabia, we don't have exact numbers, but I would think about 2,000 to 3,000 only are diagnosed from the 60,000. If we go to the higher prevalence, then in Saudi Arabia, we would have approximately 150,000 cases. Per current estimates, 1 in 3,000 adults, around 100,000 people, have been diagnosed with HCM in the States, as we said, and 600,000 remaining undiagnosed or underdiagnosed. Undiagnosed patients may be asymptomatic or have not received HCM diagnosis for the symptoms, though the reasons for this are not well described. Now, having said that, this webinar, we really want to talk to our fellow cardiologists who are interested in hypertrophic cardiomyopathy to help them, first of all, assess the burden in their of disease in their patient population. Second thing, go through the diagnosis, how to diagnose hypertrophic cardiomyopathy. And third thing, for the obstructive hypertrophic cardiomyopathy, the different options for management, medical options, innovative medical options, intervention options, and surgical options. Dr. Abir, I don't want to take most of all the presentation will, all of that knowledge will be on your shoulders to share with our fellow colleagues that have joined us. So I'm going to stop sharing and I will await for you to share. And we have a good number of participants, Dr. Abir. We have more than 278 participants now awaiting your talk. Go ahead. The floor is yours, Dr. Abir.
Shukran, Dr. Adil. Assalamu alaikum, and thank you for having me. And I'm very happy with with all our colleagues who had joined us. This really shows us how important this topic is and how it's not talked about enough. So I'm going to go through how when to start thinking about HCM and how we can manage these patients and follow them up. And we're going to review a few of the updated guidelines and the management on LVOT obstruction. And as Dr. Adil had eloquently showed, the burden of the disease is global, and the number can be anywhere from 1 to 200 to 1 to 500, which is considered a very highly prevalent disease. And the main reason for this type of hypertrophy is genetic variant. As you can see, up to 25% of these patients may have a cardiac myosin binding protein abnormality or myosin heavy chain abnormality. So 25% are a genetic predisposition, and they have a familial inheritance. So that's why, and it's autosomal dominant. So it can occur in every generation, and that's why we can understand from this why this disease is quite common. So if you're in your practice and you wonder, when should I start thinking about this patient? It is, these patients can present at any age, from teenage to an older age group. It has mainly a bimodal peak that can occur in the teenage, early 20s, or then later in their 40s. And mainly these patients, they come with the shortness of breath because they have diastolic dysfunction, abnormal relaxation. They may have LVOT obstruction, mitral valve regurgitation. They have exercise intolerance. So that's why their symptoms are mainly related to exertion. They may have chest pain with normal coronaries because they have microvascular dysfunction. They have increased wall stress. Also, LVOT obstruction can lead to chest pain. They may present with heart failure. Early stage of the disease, it's HFpEF, but later, if they become restrictive physiology, reduced ejection fraction, and as we said, they also have mitral regurgitation. They frequently come with arrhythmia, and that's the most common presentation for them. They may have an unsustained VT, sudden cardiac death, or AFib. Syncope can be associated with exertion, activity, sport, especially in the young when they're at the school playing ground. They may have sudden syncope due to hypovolemia, worsening obstruction, sudden cardiac death, and family history of sudden cardiac death is very important to interrogate. They have conduction disease as well, and they have a vasoactive response. And sometimes it's just incidental due to abnormal ECG. Like patients they went to ER for non-cardiac reason. They had an ECG that showed LVH, abnormal inversion of T wave that can explain their disease. So this is how usually these patients are presented, then they are referred to us for further evaluation. So this is the algorithm that we should start thinking about. So if you had patients with the previously mentioned symptoms coming to you, and they're young, they don't have cardiovascular risk factors, they never had any intervention like congenital disease at birth, and they're coming with concerning symptoms and affecting their quality of life and interfering with their physical activity. We have to take further detail of the history, examine the patients for any murmurs, and dig into the family history. Ask specifically about sudden cardiac death, device implantation, and so forth. And then further on, we go for evaluation by ECG, echo, and cardiac MRI, and look for the hallmark signs of hypertrophy, and I'll have some slides on that, and confirm the diagnosis with cardiac MRI. Identify the HOCM phenotype, which is left ventricular hypertrophy, if it has obstruction or not. So because they can have multiple phenotypes, and this can be masked during resting. If you do a routine resting echo, you may miss it. So if you have a strong suspicion, you have abnormal septum, then you have to do a stress echo with squatting, standing, or Valsalva maneuver to pick up the gradient. And sometimes some of these patients have non-obstructive echo. And it's very important to look for family, for genetic screening. It's an autosomal dominant. So once you catch it in one patient, you have to screen their family members. And then we go down the lines of, which patient and how to manage each clinical scenario. It's very interesting that 50% of these patients, they have low gradient at rest. So you may have a routine echo and you see LVH, you see abnormal septum, but you may not see any gradient. It may not be there, or maybe very low, like 7 or 10. But when you do any provocation test, especially if patients are having symptoms at exercise or exercise intolerance, you will be surprised that the gradient may be very high. And this is the different phenotypes of HOCM. It's not just the ventricular septum hypertrophy, as you can see here, is diffuse ventricular septum hypertrophy. This is actually the main or the most common cause. It can also come with the anterior free wall hypertrophy. It can come with abnormal papillary muscle insertion. It can come as apical hypertrophy. It may have mid-wall hypertrophy, and these patients, because they have obstruction in the mid-wall, they have abnormal aneurysm at the apex. It will just pouch out and balloon and may cause thrombus formation. Or they have also, some of them may also have right ventricular hypertrophy. For the obstruction, as you can see, this is a patient who does not have significant obstruction. They have significant ventricular hypertrophy, as you can see here. This is a septal hypertrophy. They do not have a high gradient, and but some of these patients may have obstruction, as you can see in this image. This is anterior motion of the mitral valve and causing obstruction at the septum and very high gradient. And it's elaborated more on some TE images, and this is how you see the color gradient on echo. So some of these patients may come with obstruction, some of them may not have obstruction. but nevertheless, they may develop obstruction later. So we have to keep an eye on, and every time you examine these patients, you have to do the pulse wave Doppler and continuous wave Dopplers and exercise maneuvers, a Valsalva maneuver, to miss so we cannot miss any abnormal gradient that may actually develop over time. So one of the common presentations is sudden cardiac death, like resuscitated cardiac arrest, in a young patient with no coronary event. And this is the most common presentation and most lethal presentation. And if a family history persists of a sudden cardiac death, it's very important to keep an eye on the other family members, siblings, offsprings. Arrhythmia is caused by actually abnormal muscle formation, causing scar, fibrosis, microvascular ischemia, myocyte disarray. Patients may have the apical aneurysm. They have may come with non-sustained VT at exercise or rest. These patients have left atrial dilatation. They have abnormal exercise and blood pressure response. So these factors can lead to actually syncope because they have abnormal exercise blood pressure response. They have arrhythmia, VT, non-sustained VT, worsening obstruction, especially if the patient is hypovolemic during the summer, after physical activity, fasting, and sometimes it's unexplained syncope that these patients present with. So we have to keep an eye on looking at the LV very carefully, looking at the ECG, doing serial Holter, if this persists, so we do not miss a lethal diagnosis as such. For patients who are having HOCM and we are considering treatment of the sudden cardiac death, so if the patient already had a prior event, documented VT-VF, then ICD is a class 1 recommendation. If these patients had one of the following as either a family history of sudden cardiac death, massive LVH, unexplained syncope, apical aneurysm, or ejection fraction less than 50%. So you have to have a shared decision making, and considering an ICD in children, it's 2A, while in adults is 2B as a primary prevention. But this may change. The priority may change if on further monitoring you pick up non-sustained VT or a late guide enhancement on MRI. Then maybe the priority can be higher. But routine implanting of ICD, it's actually associated with harm. So if you don't have high risk factors such as massive LVH, non-sustained VT, then doing it is actually harm. But if the patient has these factors, then it's a class 2A recommendation. So you have to risk stratify your patients for ICD. And as we said about family history and family screening, so screening is by echo and ECG. This is the most common method that we are using for screening for younger patients who have genotype positive families or family history of early disease, or because each generation will have the disease earlier than the previous generation. If the father had it in his 30s, the children may have it in their teens. So you have to be mindful of that each generation may have earlier onset than the previous generation. So you start for the children and adolescents, every 1 to 2 years. Older than that, every 2 to 3 years, and in the adulthood, you can just screen every 3 to 5 years. So the other common presentation of patients with HOCM is heart failure. So heart failure can be worsened due to LVOT obstruction itself or due to arrhythmia. So because these patients, they have diastolic dysfunction, right? They have very stiff ventricles, they have restrictive filling patterns. So if they develop atrial fibrillation, they don't tolerate it very well. They may have hypertension, heart failure, pulmonary congestion. So it's very important to rate or rhythm control and anticoagulate these patients. We have to also think about LVOT gradient. If you're not picking it up at rest, you go and do a provocation test, and then you go down the algorithm of LVOT management. If your heart failure persists, it's not due to arrhythmia, it's not due to LVOT obstruction, but these patients either have HFpEF or HFrEF. In HFpEF, we are treating with usually beta blockers, calcium channel blockers, and low-dose diuretics. And these calcium channel blockers are non-vasodilator. Like, we're not using nifedipine or amlodipine, we're using verapamil and diltiazem. They have negative inotropy. So this is the only time, as a heart failure cardiologist, I will tell you you need negative inotropy, because these are very thick ventricles. So you need to give medication. They have negative inotropic effect, so you can relieve the ventricular cavity a bit and help the circulation and reduce the intra or the LVETP or the intracavitary pressure, and use diuretic. And diuretic management in these patients are actually very tricky, because they're volume dependent. Their gradient especially is volume dependent. So if you fill them too much, they have high LVTP. If you dry them too much, they may have obstruction and they have worsening symptoms. If the EF drops, then we can start the usual anti-failure therapy as tolerated. But again, ACE and ARB, we have to be careful not to vasodilate them too much, so they can have hypertension and may worsen their symptoms. And we treat with other medications the same as SGLT2 and low-dose diuretics. And usually when the ejection fraction starts to drop, we call them burnout HOCM, and these need to be considered for advanced therapies if they're very symptomatic and requiring multiple hospitalization. Now, if we find a gradient, let's say you have borderline gradient, you're not sure, so you have to, provoke this with Valsalva maneuvers, standing and squatting, so you can actually increase the gradient for these patients. And these patients, if they're symptomatic and they have higher gradient with symptoms, then we have to consider specific LVOT management. If we are, or we can do, so you need higher gradient, maximum provoked gradient more than 50 with symptoms. You go to specific LVOT management. If your patients are asymptomatic, but they do have a gradient, you can just follow them with repeat echo. But if they have symptoms but not generating enough gradient, you have to do the exercise test and generate a gradient, and then go for a specific LVOT therapy. So what is the specific LVOT therapy? So we are all convinced right now that this patient had exercise symptoms, mainly shortness of breath, syncope, chest pain. Patients have provoked gradient maximum of 50. If you already have a gradient of more than 50 at rest, then probably you should not be doing provoked test. But if you don't, then you have to do the provoked test and you will find the gradient. Patients are symptomatic. Then you start with beta blocker as class 1. If not tolerating or still symptomatic, you either verapamil or diltiazem, one of these two. Still having symptoms, we can do disopyramide, which is not commonly available nowadays, and the other newer therapy, which is mavacamten, and we have slides on that. We can still start that. And if patients are not benefiting from medical therapy, then the septal reduction therapies like myomectomy or alcohol ablation come. So you have 3 lines of medical therapy before we go to invasive therapies. And these recommendations are for recent 2023 ESC guidelines. Again, it's a class 1 recommendation to do a non-vasodilator beta blocker, so not Enderal or Cavidolol, because they may worsen the gradient because you are creating a vasodilator in the after the aortic valve in the aorta, and then you are worsening the gradient. So be careful. Just use selective beta blockers and not cause a lot of vasodilatation. And the same applies to calcium channel blocker, not vasodilators, but rate limiting negative inotropy that can help in reducing the gradient. Disopyramide, the same. You use it to the maximum tolerated dose, and the cardiac myosin inhibitors. You start with low with good surveillance of the LV function and the gradients, and titrate the dose as tolerated. And it was a class 2A recommendation in the ESC guidelines, but now with the updated guidelines of the American Heart Association, they actually considered mavacamten as a class 1 recommendation, that it should be used after beta blocker and calcium channel blocker to prevent further, symptomatic LVOT obstruction prior to considering invasive therapies. So Just to summarize the clinical presentation before we go into the details of the newer guideline therapy, you have patients with the normal, these patients may have a normal life expectancy. In the majority of the patients, they have kind of a stable disease. But some of these profiles may change. And as you know, anything in medicine, in heart failure, it's a progressive dynamic disease. Condition may change. And that's why we have to follow these patients annually. And the profile may be a sudden cardiac death, as we mentioned. They may come with progressive heart failure, either obstructive or non-obstructive, and they end up with end-stage disease. And they may have atrial fibrillations and thrombosis and stroke. So around 46% of the patients, these are the patients who have a so-called benign or stable pathway. 43% of them will have a progressive symptoms due to obstruction. 39% of these patients may have obstruction. This is a big number, actually. And a non-obstruction is only 4% related to heart failure. 6% may end up with sudden, have a sudden cardiac death event, and 17% may have AFib and stroke. So you have to really consider these numbers. So almost half of them will have some degree of obstruction at some point in their life. So going to the new therapy, which is very interesting, and we have hands-on experience on it that made considerable benefit for the patients. So mavacamten is a selective reversible cardiac myosin inhibitor, because this is the abnormality that occurs in HCM patients due to the genetic factors, and causing crowdedness of the myocytes, further overlapping of the myocyte that really cause stiffness of the ventricle. So what does it do? It actually breaks down some of these myosins. So you have kind of a relief in the crowdedness of the ventricle, and helps the muscles to relax and reduce the cardiac filling pressures. I'll show you two studies that was done for these patients. The first is Explorer HCM study. It's a third phase study involving 250 adult patients with NYHA class 2 to 3 obstructive HCM with LVEF more than 55% and LVOTP gradient more than 50 at rest or with provocation test diagnosed with Valsalva. So if these patients were presented with these symptoms and echo criteria, they were randomized to being, they were one-to-one randomization to receive mavacamten or not. And the dose was started as 5 milligram daily, and then over monitoring, they were increased to further to 10 and 15 milligrams. And then they were followed, they were optimized over 30 weeks and followed after 8 weeks further. Yes, these patients had background therapy as the guidelines recommended, almost equal number both in mavacamten and placebo group, 76 to 74%. They were on beta blockers, and 20 and 13% of all on calcium channel blockers. So all had the guideline recommended therapy before adding mavacamten. And so what was our endpoints? So change in exercise capacity measured by VO2 or symptoms. So it's very important to elaborate that whenever we are doing a study like this, we have to have a objective symptoms, quality of life questionnaires and so forth, and a subjective endpoint and an objective endpoint. And for those who work in heart failure, they know that the VO2 is a very strong prognostic marker in heart failure patients and in many cardiac diseases, actually. It was a combination of both symptoms and measurement. And they also had a quality of life questionnaire and the post-exercise LVOT gradient as secondary outcomes. And we'll look into those. So as we said, the background therapy was equal in both groups, and these patients had class 2 and 3 symptoms, actually. So they were significantly symptomatic. They had supranormal ejection fraction as expected in HCM patients. Their gradients were actually, maximum was quite high, around 72%, 72 millimeter mercury. So it was quite high gradients in these patients. So what did we see? These patients had achieved a primary endpoint at 30 weeks. So patients with mavacamten had a better improvement in their symptoms and the VO2, around 37%. They had shown significant improvement. And also, there was a significant reduction in post-exercise LVOT gradient after using therapy. So it's very impressive if the mean gradient, from 86 dropped to 38. This is a huge reduction over 30 weeks. And as well as we've seen that we did not achieve that actually in placebo. So placebo, there's no difference. This was the reason these patients' symptoms improved, their quality of life questionnaire improved, as well as their VO2, maximum VO2 improved. And the mean standard deviation for LV ejection fraction was, the mean was 74% at baseline in both arms. And, you know, because mavacamten, again, acts as a, causes some arrest in the myosin, you worry that, you know, I'm losing muscle mass. You worry about reduction in ejection fraction and negative inotropy, but it was not significant. They dropped by around 4%. So it was not significant enough that it led to discontinuation of the therapy, but it's something to be mindful about and monitor patients for. What I like is, you know, whenever you start therapy, you don't want to wait 6 months to see an effect, right? I have a patient who's very symptomatic now. I had to hospitalize them. I had to increase the medication. So you need something that works. And, you know, there was a significant difference in the LVOT gradient from the week 4. Means that, you know, you can see the effect within a week or within a month or 2. Depending on your patient's response or the starting dose. So it's very interesting that we had started to see the result within 4 to 6 weeks. And this maintained to be continuous, you know, over the period of the follow-up. This was the resting LVOT gradient, and this was the Valsalva. So you see these patients were quite sick, and even if their resting LVOT gradients were high and their Valsalva gradients were extremely, concerning. So even, you know, they picked the sick and the very sick patient that he usually be sending for surgery. And they had shown significant benefit in reducing the LVOT gradient and thus reducing the burden of symptoms and the risk of complication. And, you know, as heart failure, we like to look at the NT-proBNP, and there was also a significant reduction in BNP profile, meaning that you have less diastolic dysfunction, less congestion, your LVEDP is dropping. And this resting LVOT gradient was monitored at 84 weeks. So this explorer, extended explorer that they actually wanted to show us a longer period. The first one was 30 weeks, now 84 weeks, and the drug managed to maintain the same effect. And now we go back to the clinical symptoms. So around 67% of the patient had improved the NYHA class by more than one class of symptoms. So they ended up really reducing the burden of disease. And some of them improved by 2, like they were 3 and they became NYHA class 1. So this is actually very, very significant improvement. And this one is very, very important as well. So it's the same philosophy or the study design, it's the same study design, but these patients were actually worked up and decided to go for septal rejection surgery or therapy. And then they were randomized to be on therapy or not and see how many patients did not require intervention. So patient's decision to proceed within, prior to 16 weeks or patients did not, they were not eligible anymore. So it's very interesting that your patient was decided to go for surgery, but you gave a trial of therapy and then you reevaluate the patient, or you actually interview the patient if they think they're better and they want to proceed with surgery or not. So this is an interesting concept. And this also had shown that we actually reduced the number of patients who were already planned to go for septal reduction surgery, and they did not require it, which is, it's an invasive surgery, and we were managing the patient medically, and we had succeeded in improving their symptoms and their gradient, and they did not require surgery. So this, we cannot say from now that, maybe later on they will require at some point. We don't know that from this study, but if you could delay an invasive procedure based on medical therapy, then that's better. And they also had, LVOT gradient was measured both at rest and exercise, and we have reproduced the same effect again in this study. So you have Explorer and Velour, both treatments had shown, studies had shown the same data in treating the effect of mavacamten on hook. And the other endpoint, as we mentioned in the previous study, improvement in NYHA class, improvement in quality of life questionnaire, improvement in BNP, and improvement in other cardiac troponins, all had shown statistically significant reduction that favors the treatment with a myosin inhibitor, mavacamten, over placebo, or just treating with beta blockers and calcium channel blockers. There are some things to be aware about. Hypersensitivity to these medication. We cannot allow to be used during pregnancy. If a woman is in a childbearing age, we can start the therapy, but we advise her, if she's planning pregnancy, you need to stop. Because the function of this drug is through the CYP enzyme, so we can have to check the CYP enzyme actually before we increase the dose, as if they are, fast metabolizers or not, or poor metabolizers or not. So usually the starting dose clinically is 2.5, but before we increase the dose, we have to check for the status of this, and we should not use any other medication that works on the cycle. So I would like to conclude this talk with some challenging questions, because, although we have talked a lot about the clinical presentation of the disease, the management, and how to do screening, we still have a lot of challenges in our community, in our healthcare system, in our patient population, that make us, missing the diagnosis of HCM or missing screening. We don't have because these patients may have variable clinical presentation and age of onset. So you have really big spectrum of patients or presentation that we need to be mindful about. We don't have a sufficient family screening program. Sometimes we want to do the family screening, but maybe the family members, they don't want this. So you have to do a lot of counseling. They don't want to label their children with the disease. There are a lot of things that can come up. So you have to do a lot of counseling, send the genetic test first for the affected. So we always, there's we call them the first member in the family that got the disease. You test them. If they have the gene that can be autosomal dominant and can be passed on to their offsprings, then you have to really do counseling and then start screening for them and really discuss this with the family. And put the effort to catch these patients early. Sometimes in the late presentation, they already have dilated hypokinetic ventricle with wall thinning. So we don't know that this patient was actually a HCM patient. So we missed the window for them and for their family members. There are something called physiological hypertrophy, maybe in athletics, in hypertensive patients. So there's kind of an overlap, and we overlook the actual disease. They may coexist, as we said, with other diseases like hypertension, valve disease. And in older group of patients, we have something we call isolated basal septal hypertrophy that we sometimes, again, overlook or not consider HOCM. We think, okay, this is related to age, but they may be a HOCM patient that are presenting later in life. So it's very important to keep all these things in mind that, you know, we still need a lot of understanding and a lot of work to identify these patients and manage them properly. Thank you so much.
Well, thank you very much, Dr. Abir, for that excellent presentation. Even a cardiac surgeon who is considered a layperson in cardiology, I understood very well how to evaluate a patient with hypertrophic cardiomyopathy. I cannot see any questions here. Maybe there is a technical problem in the Q&A, but let me start with this. So you know, you really dissected out how the steps in managing hypertrophic cardiomyopathy when diagnosed, and we should start with a beta blocker, followed by verapamil or diltiazem, followed by mavacamten, and then the last stage is for reduction surgery or intervention. Now, are there cases where you will really omit the other steps and go directly to septal ablation or surgery?
I would definitely give a trial of medical therapy. And at least, as you've seen in the study, the effect of therapy can actually occur within 4 to 6 weeks. So we don't have to wait for too long. We start the therapy, we monitor these patients closely, and we have to revisit our decision within maximum 3 months. You start, beta blocker, you reintroduce verapamil maybe within 2 weeks, 3 weeks, and if your patient's still symptomatic, we started the mavacamten, patient's still symptomatic. So within 3 months, you should know if this patient is going to respond to the medical therapy or not. So close follow-up and monitoring these patients is very important.
Okay, and for mavacamten, the medication, if it's stopped, like for example, you achieved success with it, and then suddenly for a reason or another, if it's not available in their local hospital and they stopped it, would that reverse the good effects of the medication?
We don't have enough data to support that. We have stopped in the trial. I mean, we had to stop medication for the patients who were dropping the ejection fraction because of the negative inotropy. So at some point, maybe, yes, we'll have to stop the medication, but be mindful that these symptoms would reoccur based on the physiology of the medication and the disease. So if for whatever reason, intolerance to medication or other contraindications, we have to stop. So we have to, inform the patient your symptoms may reoccur, and you need to inform us if this happens.
So this medication is a lifelong medication in general.
Yes, correct.
For patients. Now, the third question is for patients that have SAM, and with that, sometimes there's a clear mitral valve disease. Would you recommend that to go for surgery immediately, or start on the medication, assess the mitral valve later on? Or if you have a SAM with a severe MR, would you just directly...
Yes, based on the recent guidelines, we have to differentiate if this is a primary mitral valve disease or is this really due to the remodeling effect of the ventricular hypertrophy. And if it's only because of ventricular hypertrophy and the septal hypertrophy, then it's not recommended to intervene on the mitral valve. We need to focus on reducing the gradient, reducing the obstruction, and then reassess the valve. Usually, we expect that the gradient of the valvular regurgitation will improve if we actually target the primary problem.
Fantastic. In the last study you presented, the mean gradients across the LVOT were very high, were in the 80s. And in the study, it was managed to be taken down to mid-40s, which is still severe. So would you expect that gradient will go down more, because a lot of those patients are young patients and many of them are athletic patients, in fact.
Exactly. In Valor, they followed up to 16 weeks, and that in that study, it was because it was 16 weeks only, it was reduced to the mid-40s. But in the extended trial that Explorer extended, it came down to mid-30s with the longer follow-up, with like beyond 30 weeks. So it takes time and optimization of the dose as well. If we see that the patient is not getting that effect, then we may need to increase the dose for these patients. The starting dose is 2.5, but the maximum dose is 15. So it's dose dependent also, the effect.
Okay. Because mid-30s is also considered a severe
So
gradient.
that's why their primary endpoint was mainly the VO2 reduction in or improvement, sorry, of the VO2 to more than 3 points from their starting, and improvement in symptoms, improvement in BMP and quality of life. So it's more of a composite endpoints that will help us make the decision. So it's not only the gradients, also the symptom burden of the patient.
So when would you say to the patient, okay, you're stable in your medications, and now your life expectancy is as normal as the normal population?
It's difficult to say that because, you know, it is a progressive disease. They may not have worsening or obstruction, but down the road they develop heart failure due to another etiology or arrhythmia, because it's a cardiomyopathy. You have abnormal ventricle, and the disease, as you've also shown, it can affect both ventricles and has affect the conduction system. So the disease may progress. You know, it's a progressive disease. So at least for the period of time, we can improve their symptoms. But if I can tell them, you know, you're normal and you have, you will not have any deterioration or down, you know, prognosis could be poor. So it's actually it's difficult to tell them that because it's an abnormal ventricle, it's a progressive disease. So this may progress at you know, at a different pattern later.
Now, in extreme cases, when would you say to the patient that, no, you need a cardiac transplant, or no, you are fit to go for a septal reduction surgery?
So cardiac transplant, we have to look at the criteria for advanced heart failure. So if these patients, they have a burnout. If their EF drops, you know, even without treatment, means this is a very burnout ventricle. So any drop in ejection fraction below 50 means like this ventricle will not benefit from, you know, septal reduction or anything, because this disease is becoming very advanced. And we also look at the other criteria of advanced heart failure, recurrent hospitalization, refractory heart failure, requiring, you know, maybe other end organ dysfunction due to low cardiac output, pulmonary hypertension. If they start to develop pulmonary hypertension because they have very high left-sided pressure, then you have to discuss advanced therapy. So we like to look at these patients as we look at any advanced heart failure patients. We follow the same criteria: clinical, arrhythmia, pulmonary hypertension, hemodynamic, recurrent admission, to decide for bladder transplant.
Fantastic. So if you are designing for Saudi Arabia a screening program for hypertrophic cardiomyopathy, how would you envision it?
We have to categorize patients based on, first, you know, if we have patients who family members, I think that's where we start first. If we have already, you know, in our own hospitals and institute, we have patients who are diagnosed with HCM, we have to start there, as they're the primary contact for us to screen their family members based on ECG and echo. That's all we need. And then you start picking up more and more patients. But the baseline screening for HCM would be ECG. If you find abnormal ECG in young patients, then definitely, you know, patients who don't have any family members or any family history of disease, then ECG screening should be sufficient. So if you have abnormal LVH or T-wave inversion, then you're probably looking at some pathology there.
And is there any overlap between obstructive and non-obstructive disease? And would you also screen family members with an index case of non-obstructive hypertrophic cardiomyopathy?
Yes, we would. Like we screen for sudden cardiac death, non-obstructive, obstructive. The screening, as long as we label this patient as HCM, the same screening applies to to all phenotypes, let's say.
Okay. Now, my last question is for mavacamten. Is it available in all hospitals? And I'm talking here on also the peripheral hospitals and the Ministry of Health and other sectors, or and is it approved from in the formulary for all the major sectors, or how's the availability of the medication?
So once it's Saudi FDA approved, we are able to request the medication. So when we started the HOCM program at PSCC, we started requesting for patients per se, and then we requested to be added to the formulary. Since it's a Saudi FDA approved, we have the patient population, the benefit, the evidence or the benefit, we can request to be added to formulary. But before we add this, we have to understand that we need HOCM programs. Before we start adding different therapies to our formulary, we have to know we have a team, a multidisciplinary team that evaluates the patients, that, the dedicated clinic and programs. So you can actually have a dedicated pathway for these patients. And these centers could be authorized to be called HOCM centers. And then these advanced therapies can be made available for these, centers that are called HOCM centers.
Fantastic message, Dr. Abir, and excellent presentation. And I think the last part of it is that we need HOCM centers. We are available at the Saudi Heart Association and the National Heart Center to provide all the support for all the participants. Today, we have 315 participants with us who are with us from the beginning till the end, till now. I'm really happy and joyful for the people that are here that are eager to learn more about this disease that is misdiagnosed and underdiagnosed in the vast majority of cases. We need to establish HOCM centers. We have the expertise in, especially the high-end hospitals, where in King Fahd Medical City, Prince Sultan Cardiac Center, King Faisal Specialist Hospital, National Guard Hospital, University Hospital. We do have the expertise, and we are willing through the National Heart Center and Saudi Heart Association to extend a helping hand to any cardiac center to establish a HOCM program and start diagnosing those patients and starting them on the algorithm of medications, so we could really improve their symptoms, improve their lifestyle, improve their survival, and improve their quality of life. At the end, any final closing remarks from your side, Dr. Abir?
يعطيك العافية دكتور. I think we have to, I would state the same as you mentioned, that we have to have a high suspicion index of these diseases, especially in the young patients who presented with cardiac symptoms or unexplained symptoms. We have to keep our minds, open to look for these diseases.
Thank you very much, Dr. Abir, for this excellent talk. Thank you all for participating with us and listening to what we have said today. I received many thank you letters from our participants. The last is Dr. Yasser Al-Sawaf. Thanks a lot, Professor Adil, for your great information. Thanks, Professor Abir, for the elegant presentation. Thank you all for being with us in this fruitful hour, and looking forward to more and more about hypertrophic cardiomyopathy and other topics from the platform that will provide you all the medical, the scientific knowledge you need to manage heart disease patients. Thank you very much, and have a great night.
Thank you so much. يعطيكم العافية. مع السلامة. شكرا لك.